So I'll be brave if you're brave. I'll be brave, but only if you're brave.
Good evening, everyone. Welcome to tonight's living room. Thank you all for joining us. Those of you in the room, I'm so happy to see some old veterans, some new faces as of last month that have come to join us, some new faces as of this month, and a face I haven't seen in quite some time over here in the corner. Welcome back. Thank you to all of you joining us live. We're thrilled to have you here this evening. For those of you online and in the room, you might notice that the setup's a little bit different. We spent a little bit of time trying to cozy it up a little bit, make sure we've got those big 4 letters behind my head to remind everybody that this is a place to come to when we're looking for hope and connectivity. So welcome. Those of you, all of you here, all of you watching, I'm hoping are on the reminder list about tonight's event. So most of you are aware of our topic tonight, and our topic tonight is women and lung cancer. There's men in the room, men I'm sure who are watching from their living rooms and or who will come back and watch post live and thinking, how might this impact me? And I think tonight you're gonna learn a lot, and you're gonna find out how what we know, but more importantly, what we don't know about women and lung cancer affects lung cancer as a whole. So we are thrilled to have Dr. Narjust Florez from Dana-Farber, and I'm gonna let her introduce herself in a minute. I know she was expected to be here live. She sends her sincerest apologies. There was an airport mix-up and she was unable to get here in time, but thank goodness for technology and GoTo's ability to pivot and Dr. Florez's ability to pivot. We're bringing her in virtually tonight. I wanna remind everybody online and those in the room, this is an open forum. We bring this programming to you for you. So if you have questions throughout, please don't hesitate to, if you're online, type it in the chat. Michelle's over here moderating and we'll get your questions to Dr. Florez. And if you're in the room, please don't hesitate. Just don't forget to pick up a microphone so people online can hear what you have to say. With that, I am going to turn it over to Dr. Florez to give us a little introduction of herself, who she is, where she's from, if I didn't mention Dana-Farber, and why lung cancer is an area of interest to her. Dr. Florez.
Hi, everybody. I'm very sorry I couldn't make it. There was really in-flight text messages and a little period of time in which I was homeless with no hotel in the wrong city. And now I need to explain to people why I'm bringing 4 vibrators and a lot of vaginal lubricant back to Boston. The guy in TSA this morning asked me, what are you doing? It's like, I'm talking about women and lung cancer. And the guy's like, go there. But now I'm flying back with that. So yeah, I'm so sorry I cannot be there. I even told my grandma last night I was gonna be there in person, because my grandma has watched the living rooms before. She doesn't speak English, but she likes to watch them. So she's like, oh, finally, I can see you, instead of a little square. And I had to call her. I think that was harder than texting Michelle. I told my grandma that her plans changed. So I'm Dr. Florez. Before I was Dr. Duma, so I have done 2 other living rooms during that last name, a little rebranding. And I'm a thoracic medical oncologist at Dana-Farber. I focus on younger patients and women with lung cancer, and also the associate director of the Cancer Care Equity Program. So I have, fortunately, with my team, opened 2 cancer diagnostic clinics in very underserved areas of Boston to accelerate the process of lung cancer and all cancer diagnosis. My interest in women with lung cancer started with a patient that entirely changed my life. I was supposed to be a agnostic oncologist, and a younger woman, when I was at the Mayo Clinic at the mothership, changed my life. She was facing stigma of the disease, and through that journey and my training, I realized this was my calling. And unfortunately, 2 years ago, my Nana, my second mother, was diagnosed with lung cancer as well. So I had learned a lot about how to be a caregiver and how to be a better doctor, thanks to this experience with my Nana, and how the community comes together, but also how women often are ignored or gaslighted by the healthcare system, like my nana was. She would continue to say this is this, and they continue to tell her, oh, that's cataracts, you have cataracts. And my nana's like, I'm 60 years old, how can I have cataracts? And in fact was metastasis to the choroidal area. So it's my pleasure to be here. I'm so sorry I cannot be in person. I usually don't look this nice, but I got myself together so I can at least alleviate not being able to eat there, so you can see me a little bit nice.
Thank you, Dr. Florez, and we certainly miss having your energy here in the room, but it, fortunately for you, comes through loud and clear on the screen. So thank you so much for being here. I think I know we've got a fairly heavy agenda tonight. Sorry, there's a little feedback. A fairly heavy agenda tonight, so I want to jump right in. And I want to ask you first to talk a little bit about, we know, particularly in the last decade or so, there's been an increase in diagnosis, particularly in younger women. Can you talk a little bit about what we're seeing there?
Yes, and before we talk that, I brought props, Danielle, I brought props.
Oh no,
so I brought even a journal, the article that we just published. So this is to everybody. It's just, it was just published in print in Clinical Lung Cancer. And this is a large summary. It's called Lung Cancer in Women, the Past, Present, and Future. And we really wrote it in a way that everybody can understand it. And we break it down. But let's talk about the incidence. So initially, lung cancer was perceived as a disease of men. And in part was because it was heavy tobacco use in men. But in the 50s, 60s, and 70s, the tobacco companies started heavily marketing to women. And they marketed with things that were very insecure as women: weight and a role in the workplace. So there are campaigns of tobacco saying, if you want to remain slim, and that's how the use of tobacco increased on women. Then we saw the numbers of lung cancer increasing. But in addition to that, we have seen the number of lung cancer cases in women increasing despite tobacco use. So this is not only a phenomenon of the marketing by the tobacco companies, but it's also our intrinsic factors that we're trying to understand. Since 2018, for the first time in history, younger women are getting more lung cancer than younger men, despite the perceptions outside that is a disease mostly of men. And this phenomenon is not only a phenomenon in the US. It has been described in Brazil, France, the UK, Spain, India, and Australia. So it's something that's happening globally, and more women are getting the disease.
Yeah, and I think in particular, the numbers indicate women, when we say younger women, we're talking about women between 35 and 54, roughly, right? And I think one of the challenges that we're going to talk about next revolves around this increase in women being diagnosed. Some of the things that you mentioned are factored in, them being marketed for cigarettes and an increased use in tobacco. But there's also a lot of women who have never smoked that are being diagnosed. And when we're looking at this, I guess my question to you is research keeping up? How is research keeping up, or are they, the proverbial they, keeping up with this increase in order to determine what gender differences might there be?
So I call lung cancer a disease of women, and it's a disease of women. When you remove tobacco exposures, 2/3 of the cases of lung cancer globally are in women. So when we remove that cloud, because I call it a cloud because it brings a lot of negative things, the disease is a disease of women, 2/3 of patients. So that's 66% if you want to do fractions and we want to do percentages. Unfortunately, precision medicine has forgotten the number one rule, and that men and women are equal but different. We're differently biologically speaking in many aspects. So let's break it down how we're different. Women have higher estrogen receptors in the lung compared to men. We have a particularly enzyme, a cytochrome enzyme in women that has lower levels. So when you are exposed to tobacco, you have lower capacity of breaking down those metabolites or toxins, right? So women require less packs to develop lung cancer compared to men, because we have lower levels of that enzyme that inactivates some of the dangerous aspects of tobacco. In addition to that, pollution. Pollution has been found to be different in women versus men, and a lot of this has been studied in Asia. There's a particle called P as in Peter, M as in Mary, number 10, associated with outdoor pollution and lung cancer, but that particle is significantly higher in women lung tissue compared to men that live in the same area. So when we are exposed to outside pollution, we're also a higher risk for developing lung cancer compared to women. So that's some of the biological parts. Immunologically speaking, we're different, right? As women, biological women, and we are designed, evolved to carry a host, and that's the fetus. So our immune system is very different. And a lot of the therapies that we're using for lung cancer are based on immune response. So women tend to have a different immune response because we have to host, right? We have a tenant for 9 months and only shares 50% of our DNA. So our immune system adapts to not reject the fetus. That's just one of the basics. And when we're studying vaccines and lung cancer, we see that women have a higher immunologic response, but it dies very quickly. So it means we develop the antibodies, but it doesn't last, compared to men that are able to have a medium response, but the antibodies stay in the body for longer. And finally, something that is very different, also biological speaking about women versus men, is how we metabolize treatments. And we're going to talk about that later. But those are the biological differences. And they're the societal differences. So I talked to you, Danielle. I have a group of flight attendants that never use tobacco, but flight attendants is still today in 2024. In my own flight this morning, there was one male flight attendant. So back in the 50s, 60s, 70s, and 80s, a lot of these women just go recycle smoke. So I have 5 flight attendants that have secondhand smoke. So when women and men are asked about secondhand smoke, women report 79 of the women's reported secondhand smoke exposure compared to 21% of the men.
Yeah, I think it's fascinating. And before we move on to the next sort of question or topic, I just want to kind of break down what you said in very basic lay terms. So women's bodies, because of X, Y, or Z, respond differently to whatever mitigating factors might come into their lives, whether it be indoor or outdoor pollution. What else did you say? The less packs.
To break down.
Yeah, so the less packs per year is interesting to me because I think when I think about screening and the current qualifying criteria for screening, it's a pretty heavy pack year history, effectively based on this conversation geared towards older men, right? As opposed to these younger women. So it's even a challenge when we're looking at screening this population of women because of the current guidelines for screening. That's just, I just wanted to kind of bring that sort of full circle, because it's not just a once diagnosed, it's really when we're looking at screening, which go-to is pushing. It really does not include the women that Dr. Florez is talking about today.
Just to add to that, Danielle, women are diagnosed with lung cancer at younger age. Yeah. So the 50-year-old cutoff, it tends to exclude a lot of women. So we require less packs. We're younger at diagnosis, and we also may have quit smoking. The quits have been removed from the guidelines, thank God, but that excluded a lot of women because women quit long time ago and they were excluded. I have a lot of women that didn't qualify for lung cancer screening for a year or two because they quit 17, 18 years ago.
Yeah, and just to, again, expand on what Dr. Florez just said, the qualifying criteria had a significant pack year history, but it also said that you can't have quit smoking longer than 15 years ago. And recently the American Cancer Society said we need to get rid of that 15-year rule and open it up to just former smokers regardless of when they quit smoking, which is a huge step in the right direction, but we're still challenged until USPSTF jumps on board as far as at least getting it covered So I don't want people to think, oh, I all of a sudden now qualify, because there could potentially still be a reimbursement issue. Still worth having a conversation with your healthcare providers about, though. And I always want to point that out to you all in the room, because you are our champion advocates for speaking to people that you know who might qualify for lung cancer screening. It happens not often enough, as we all know, based on the number of people actually getting screened. Okay, I'll get off that soapbox for now. Let's talk a little bit about delays in diagnosis, Dr. Florez. What does this mean, number one? And are there differences in these delays when we're looking at men versus women? Because there are men who also experience delays in diagnosis, but how is this different between men and women?
Well, there are delays in diagnosis for both genders. And they're determined by many factors, particularly social determinants of health. We know that patients in rural U.S. are less likely to be diagnosed early, because when I was at the Mayo Clinic, I had some farmers that needed to drive 200 miles to come and see me. So that can be challenging. There are many populations. But when we try to, because we're talking about women in lung cancer, women with the same symptoms, age, and risk factors take twice as long to be diagnosed with lung cancer compared to men. And there are many factors that break that down. But the number one factor that we saw in that review, and now we're doing a prospective study, is that, and I'm going to take the fall on this, healthcare providers don't associate lung cancer with women. And I can tell you, I'm so tired. I sometimes go and call these people and hunt them down if I had the time, because a week ago, I had a patient that went 8 different times to a healthcare provider office with cough. What did she go in between, Danielle? She got a mammogram, she got 4 COVID tests, influenza tests, and she got a pap smear, but no chest X-ray. So there is no association, and that is all responsibility. It's all fault, and this is what I'm gonna die in this hill. I go to family medicine meetings, I'm going to internal medicine meetings, I go to pulmonology meetings, so we can change the face of lung cancer, because that's the first step. We need to associate the disease that's killing our women with the women's are killing, so we don't continue to delay this. Because a matter of weeks is the difference between a stage 3B and a stage 4. So there's delays. And what happens with lung cancer screening? Just to close that, women are 32% less likely to be offered lung cancer screening. And if you're a woman of color, it's 6 times less likely to be offered lung cancer screening compared to men. And these are patients that have the same risk factors, the same tobacco exposure, the same age. So we only don't diagnose our women, but we also don't offer them the pathway to diagnosis. And that's what the patient advocates that are in the room. Your voice is being heard. And I love going to the Hill with my patient advocates, because I just sit down in a corner and there are so many stories that usually the staff A is like, okay, this is important. But I feel it's very unfair to ask our patients also to have to advocate for what the doctor needs to offer. Because we offer mammograms and we offer pap smears. I get a message about my pap smear every other year in Epic. Why can't we do that for all patients, not only women? Saying, hey, you qualify for lung cancer screening. Do you want to discuss that with your doctor? Instead of putting more responsibilities in our patients, particularly in our women. I had a patient that told me the other day, I had to be a good mom, a good wife, a good sister, a good daughter. I need to cook, I need to clean, I need to have a full-time job, I need to exercise, drink water, make sure I help the kids with homework. I need to be a driver for all these kids' activities. And on top of that, I also need to go to the doctor. So it's like we keep putting more and more things in our patients. So that's what I take responsibility. We fail to bring lung cancer screening to women.
And I think that's such an incredible, impactful statement, Narjust, coming from you to, as you said, stand on and die on the Hill about, because I know in my own personal experience and those that I know, it is so incredibly true that you're gaslit, as you sort of mentioned earlier, or things are kind of excused or pushed away as some other women's disease or issue, when in actuality, when you look at the sheer cases of lung cancer diagnoses in women, it supersedes breast, and correct me if I'm, breast, ovarian, uterine, cervical, something combined, correct?
For
all of them.
mortality, yes.
Yeah, yeah. So I'm wondering, and this wasn't on the list, and I'm just, and please, if anybody has questions or comments, please grab a mic. But I'm curious, outside of folks like you who are shouting this type of stuff from the rooftops, do we know if anything is happening in med school? Are these conversations, or is it trickling down that far for future generations of healthcare providers, right? Because by the time somebody gets to you, they're already diagnosed. And like, how are we getting our primary care physicians, our pulmonologists and the like, educated on what we're talking about right now?
I think because survival has significantly improved, and now we hear many of our women talk, and thanks to social media, we're talking more about lung cancer now than ever before. When I train, Danielle, I wanted to be a lung cancer doctor since very early in my training, and people were like, "Oh, are you sure?" But now thanks to many of the voices or patients, caregivers, medical students now talk about lung cancer, not as much as I would like it. I'm biased too. But now there's more talk about it. When I train, it was like a rare disease that happened to a small group of people know what it is. So talking and normalizing it is a very good step to do it. Like, there is no stigma with breast cancer anymore. But still, my women, when they disclose their diagnosis, they're half afraid of disclosing the diagnosis. And that's not fair to anybody. And women or men, nobody should be questioned when they disclose a cancer diagnosis. And like, I saw it, I knew it, but I saw it firsthand with my mom. And she's a judge, a retired judge. And like, some people excluded her because she has lung cancer now. She has oligometastatic lung cancer. And then she's like, I shouldn't have told them. And I was like, it's their problem. Honestly, they're losing your company because you're stronger today than you were 2 years ago.
And that's going to jump us into the next question. But I have one more comment, of course, that I'd like to make before we move there. And that's what you said about electronic medical records and reminders. How easy is that, right, for someone to either get a reminder, or even for their healthcare providers to get reminders when somebody comes in for a physical or a checkup on something, just saying, hey, this person qualifies, and have they been screened? And I know there's issues with EMR talking to one another, and that's a whole other set of challenges. But if we can figure it out with something like breast, to your point, or colonoscopies, because I get reminded about those things, pap smears, all of it. I get text messages, I get emails, I get all of it. So why can't we implement that for lung? And so that's incredibly frustrating as well.
Could I add something, Danielle, to that? Sorry, and put you as an example, if you don't mind.
Yeah.
So, because I know your mom, and take into account you're a woman and you have a family history of lung cancer, your survival benefit, if you don't use tobacco, but if you use tobacco, will be the lung cancer screening because your family history as a woman.
Yeah.
You would have more survival benefit from that than your mammogram, than your pap smear, and your colonoscopy. So when we talk about screening, we always say, oh, we want to make sure everybody benefits.
Yeah.
The survival benefit for lung cancer, when you look at the numbers the right way, lung cancer screening is higher than mammograms. Yeah. And to be honest, I have mammograms. It's not fun when you get squeezed. It's not fun. So if we're able to make squeezing your tatas routine, we can make routine for lung cancer screening. It's low dose CT scan. How many of you, we all dare the pap smear, we all dare, they're very invasive procedures. Every time I had the pap smear, I was like, oh, I have a pap smear today. The entire day you're thinking about it, but we normalize it.
Yeah.
And it's less invasive to get the lung cancer screening, or just to have a conversation with your primary care doctor. My mom had lung cancer, my sister had lung cancer, I was exposed to secondhand smoke. And this, don't forget the breast cancer survivors. I have a large cohort of those. they're also excluded for lung cancer screening. And they were radiated on the lawn, and they get lung cancer right where they were radiated.
Yeah. Yeah. Did you have something you wanted to say?
The only thing I wanted to say, and that we didn't mention today, is that it's up to us girls to spread the word. You know, we can't wait for a physician that, you know, knows nothing about lung cancer or anything. It's up to us to do it and pull people together and do what we're doing here tonight, and, you know, do it more often, maybe during the day, and when girls can get off. I think it's our job.
Yeah, it's sort of this women empowerment thing, but I also don't want to discount the men who have wives and sisters and mothers and daughters. It's important that you are all listening up to for them.
And it's up to the women to do it for the men too, because that's the only way it's going to get done.
As if we're nagging.
Right?
I see a lot of women's head
Right.
nodding, and a lot of men at home are just
Yeah.
like, here we go.
Yeah.
Do you have a question? I just need you to have a mic. I need you to have a mic.
I have a comment, and only because I'm educated around lung cancer, because of mom. But the problem is, I'm going out and I'm looking for a new primary care physician, and they have their template. And what drives me crazy is they're only asking me breast cancer history, colon cancer history, and actually that's it, right? And I've questioned, why aren't actually, and I'm not even focused on lung cancer, why aren't any cancer history, right? Because if it wasn't for my education around lung cancer because of mom's diagnosis, I would have never asked to be screened. Whether it was, I mean, it's not just based on, you know, smoking history. We have a familial thing with lung cancer, but nobody's even asking.
Yeah.
And that's the problem. It's not just with lung cancer. I mean, specifically tonight, it's around lung cancer, 100%. But if I wasn't educated around that, I wouldn't know to ask that question. You know, I automatically assumed, oh, breast cancer and colon cancer is the thing to be screened for.
Yeah, and I think that's Dr. Florez's kind of point, right? Like the burden does fall on the healthcare provider, because as a general rule, not only do we want to, but we do trust our healthcare providers that they are pointing us in the right direction. They are letting us know what we need to know when we need to know it. And the reality, to your point, Andrea, is that's not always the case. We do have a generational family history of lung cancer and have been fortunate enough to pay out of pocket for low-dose CT in order to track that, because it's important to us. But not everybody has that option. Not everybody has, you know, the option to pay out of pocket for something, or a healthcare provider who will say, yeah, I'll go ahead and refer you. So these are real challenges and concerns for a lot of people for a lot of reasons.
But also, I don't think we can just focus on the health care provider knowing all the facts and being educated 100% all the time. I remember sitting in a meeting 10 years ago about how if your general oncologist wanted to know everything about all cancers, your general oncologist, not your like focused, lung cancer oncologist, they needed to read 19 hours a day just to stay on top of what's happening. And so I think that there's an education for anybody, growing up. I kind of go back to that whole home ec. In high school, you take home ec, you learned how to write a check. But you also need to learn about educating yourself and empowering yourself with just all cancers, all diseases.
Yeah, I agree. And being your own advocate is a huge part of it. The problem is you only know what you know, right? And before you have lung cancer, you might not be aware from a screen. I mean, I agree with what you're saying. Dr. Florez, do you have a comment to any of the commentary?
No, something that, this is just, I agree with everything that has been said. And I think it's both sides. And the normalization of the talk will, make it into the primary care clinic. Also at the Florez lab, we're trying to work with very smart people, smarter than me, to try to find all the risk factors for women and create an algorithm that will give us a score. because that has worked in other diseases. Make it simple for the primary care doctor. You put the numbers, family history of lung cancer, Asian female, for example, history of this lung disease, tuberculosis, for example. Those are risk factors, previous breast cancer, radiation, and that gives you a score. And that score will put the patient at low risk, middle risk, or high risk. We're trying to create this not to tell people not to do their job, but just to get my women diagnosed. Because I don't like focus. When I used to go to the family medicine meetings and I used to say, it's you don't do your job. My sessions weren't very well attended. Then when we changed the conversation about let's do this together, it can be your neighbor, it can be your mom, anybody can get this disease. Let's stop thinking that it's somebody who is in a wheelchair and oxygen. That is not the majority of the patients. I have patients running the Boston Marathon. I have yoga instructors. I have an ultra marathon runner. Like these women just go and runs for days, right? So the point is we're creating this algorithm. Education for patients is very essential. Education of family members is very essential. And let's make lung cancer a conversation in the table like we talk about mammograms, right? Let's remove the stigma with the disease. It's a disease, right? So that needs to be brought out to the dinner table. So hopefully one day I can get a commercial on the Super Bowl like the Dunkin' Kings just to bring the awareness about lung cancer. Because everybody in Massachusetts is crazy about the Dunkin' Kings right now.
That's a perfect segue into our next sort of area around lung cancer, sadly, really being associated with shame, and despair and hope and hopelessness and the stigma that's attached to it. How, in your opinion, or from studies that have been done, might stigma affect women differently than it affects men?
Unfortunately, when a woman discloses a diagnosis of cancer, everybody in the audience is hoping it's breast cancer. And there is this whole pink fever about it. And yeah, I'm not very loved by them. It is okay. It's a whole pink fever. And it's like, that's the disease of women. And that just feels in the stigma when any woman gets out of that box that's supposed to be breast cancer. When a woman gets out of the box and gets diagnosed with lung cancer, it gains blame right away because she's outside of the stereotype. So I have seen a lot of isolation, particularly in younger women. They don't know anybody who has the disease. We just started 6 months ago a support group only for younger patients. They don't have anybody. They have a lot of stigma because as soon as you say you have lung cancer, by the way, it's like, do you smoke? Who cares, right? And right away, people actually believe that that person will live very limited time. So as a coping mechanism, they also isolate the individual. I have patients that have been isolated by family members, by their church community. I call a pastor once and I say, I'm going to see you down there, if you keep doing this to my woman. But they isolated because we try to avoid the feelings of losing somebody to a disease. And lung cancer had this reputation, the patients don't live longer. And that's not true because we're full of survivors. I have a patient that has been with me longer than I have been a lung cancer doctor. And so there's a lot of isolation. You feel alone. You don't want to disclose your diagnosis. And that leads to significant depression and anxiety. So women who tend to keep the diagnosis with themselves have higher risk of depression, have higher risk of suicidal ideation. So a patient that already, a woman that, or people that already have a lung cancer diagnosis shouldn't have added burden of the stigma. I have women coming to my clinic dressed in pink. And I have worked with many of them. Many of them feel more comfortable. But I'm so tired of seeing obituaries of my women. I don't call my patients, I call them my women or my ladies. My ladies saying die of bone cancer, die of brain cancer, when in fact was lung cancer. So even at the moment of death, they have to deal with the stigma. So that's what I say. Lung cancer should be a conversation in the dinner table, should be a conversation in social media, should be a conversation or policymakers so we can normalize it. So our patients stop carrying this burden of stigma highest suicidal ideation. Some of the highest suicidal ideation are patients with lung cancer, irregardless of sex. With women reporting higher depression and anxiety and higher isolation compared to many other patients with cancer. And that leads to, when you feel depressed, you are less likely to want to do next line treatment, less likely to embark in a clinical trial, less likely to just get out of bed. And we know the patients that remain active do better. But we need to see how stigma presses our patient and pushes them to isolation and depression. And that's what this living room is so important. I have 11 patients from Europe DM me today saying, are you going to record it? It's very late in Europe, but I really want to watch it. So the sense of community of belonging is one of the resources we have against stigma. I have 2 patients that are besties now. They met in my living room and they were very depressed. But now, so that's what making it normalizing is so important, because now these 2 women found each other in my waiting room, and then now they can share that. And that's what the living room is so important. And I keep coming to this setting.
Thanks, Dr. Florez. Anybody, Michelle, are we good online? I'm just doing a quick check-in. So now I want to jump into something that we touched on a little bit ago, and that's how gender differences relate to tolerability and response to certain therapies. And let's start in the long-term sort of adverse events in different women. I mean, the good news, and we talk about that all the time, especially with the advent of targeted therapies and immunotherapy, survivorship is no joke. To your point, Dr. Florez, people are living a long time, sometimes decades or more, with late-stage disease. How is some of that survivorship and the adverse effects different in women?
So one of the things is that we have to change the narrative that you should be lucky to be alive. I hate that when I have patients that are like, oh, I shouldn't complain. No. Tell me what's happening. And that's what sometimes the wife is very helpful for the wife or the husband, because I get the elbow. Tell her why you told me, regardless of gender. So one of the best things about side effects is to have a spouse. Okay, because the spouse can like elbow the patient during the visit and say, it's like, you are spending a lot of time in the toilet. So, and that's what is also good to hear the caregivers. The caregivers are an essential part or care team, as good as the surgeons. Probably the caregivers give me more information than the surgeons. So women tend to have, first, the gender bias that we talked at the late diagnosis also affects side effects. There is a belief that women report more side effects than men and they complain more, but that is not supported by data at all. Women report side effects 11% less than men in lung cancer. So the whole perception that we're nagging and that we're always complaining is not true. 11% less. And when we talk about chemotherapy, 30% less. So women don't complain much, but we have more side effects. Why? A lot of these chemotherapies were tested in men. Healthy clinical trial men. Men with a performance status that were able to still work and get chemotherapy. Men that were in their 50s and 60s. Some of the early lung cancer studies, over 70% were men. So we're testing these drugs in a majority men population. We come with a dose, and then we try to treat all women with that dose. Try to put yourself in a pair of jeans that are created for men. They don't fit right? Like, I know there's some people that may like that fashion. It's okay, but we have curves. It doesn't fit. Those jeans don't fit, right? Or shoes. It just doesn't fit. So the same thing happens. So now we're learning that women have severe side effects compared to men. One that is very particularly is neuropathy with the taxanes. Women are most likely to have severe neuropathy and permanent neuropathy with taxanes compared to men. And this is the tingling sensation in fingers and toes after the chemotherapy that can last a very long time. Another side effect that's more common in women is nausea and vomiting. So when a woman is telling you we have nausea and vomiting, it's because they truly have it. Hey, raise your hand to the women in the room if your PMS gives you nausea, right? We have a high tolerance for nausea. And the people that have humans, that have made humans, right? They have nausea during pregnancy. So actually women have higher tolerance for nausea. But when women complain about nausea, are less addressed compared to men. So we have higher side effects, but we are not hurt as much. And it has to do with because women supposed to be nagging and always complaining, but the data doesn't support that. So more side effects for chemotherapy, significant permanent side effects. For all therapies, higher rates of diarrhea, nausea, vomiting, and long-term side effects, higher rates of skin toxicity with targeted therapy, with EGFR therapy, those rashes, higher weight gain with many of the targeted therapies. And we forget to talk about how weight gain can be destructive to patients' self-esteem, right? ALK inhibitors can give you 10, 15 pounds. MEK inhibitors can give you 20, 30 pounds of weight gain. And let's all be very honest, nobody feels comfortable when whatever genes don't fit. So the drugs were tested mostly in women. Women have more side effects and are also less likely to be hurt by their oncologist.
I saw a hand raised. We did all of that. Let's talk a little bit about survivorship challenges, particularly as they relate to some of the social issues when it comes to women. I know we touched on it a little bit earlier, but if we could let's talk a little bit more specifically about it.
So there are more lung cancer survivors that are women than men. Why? Because women with lung cancer live longer. And this includes non-small cell lung cancer and a small cell lung cancer. So both of the large subtypes. Regardless of stage, women live longer, including stage 4. At 5-year survival, significant women live longer. So what that means is the large pool of survivors are women. And the large pool of advocates that are survivors are women, right? So this system is being driven by the work of women, but their survivorship needs have not been studied in detail. Let's talk about survivorship in many aspects, Michelle. But I want to make this a little more interactive because I think I'm doing a lot of talking. So let's make this like a little stand-up comedian. Anybody in the in the audience wants to say one issue about survivorship, and we can kind of break it down about the unique needs of women. Anything.
Crickets.
I don't bite, I promise.
Let's go. Say something.
Yeah, it's crickets.
All right, let's talk about financial toxicity. How you guys feel about that, ladies and guys? Yeah, nobody talks about, let's talk about the realities of the financial toxicity associated with lung cancer and survivorship. This affects everybody, but women unfortunately are significantly paid less compared to men, right? We know that. As women, we earn less money to the dollar compared to men. So financial toxicity tends to be higher in women. We get paid less. Additionally, there is a higher number of women that work as single mothers, and they have higher financial toxicity associated with that too. Don't say there's no men, they're single parents. That also happens, but statistically speaking, majority of women. So they have higher financial responsibilities, right? We're talking about money. What happened also? Women tend to be the caregivers of all. So they tend to distribute their wealth to family. So when cancer affects them, there's less savings. And it's not the belief that women shop, that we shop and buy. No, we run the budget in the house, but we tend to give whatever we earn to our family more. So when lung cancer comes, there's less savings. So we earn less. We tend to mostly care children more as single mothers. And we also tend to give wealth to other family members, including children and parents, for example. So when cancer comes, it affects the entire financial nucleus of women. And doctors, providers, caregivers are not very good talking about money. And that was the first thing I wanted to talk about survivorship, because cancer is expensive. Cancer is a financial burden. Cancer can take our savings and is the #1 reason of bad pregnancy for health-related things. So that's what I talk about my women, and I talk about my men and non-binary members about survivorship and financial toxicity, because we don't talk about it, but it's still an issue. So women tend to have that need. And what can we do to talk about financial issues? I ask my ladies how we're doing in the financial sphere. And at the beginning, there's a lot of, shame about talking about it. And I tell them stories. I moved to this country and my grocery store used to be Dollar Tree. Because, they see me in Harvard and the doctor was like, no, dear, this cardigan came from Goodwill. I love everything. So I opened the door to talk about it because we have to talk about money, and we need to talk about financial advisors are usually underutilized. And it's because we don't talk about it. And there are many grants. This time of the year is my favorite time of the year because it's still money around for grants. So I tend to ask my ladies, let's see if there's a grant. Let's figure out how we can find resources to support you during this journey. And that includes Ubers, if we can get them covered, whatever it helps. And that's what a lot of the studies I do tend to have a financial incentive, not because I'm trying to get people to complete the studies, just a way to, understanding they're donating their time to complete some of these studies. So I just covered financial toxicity. I wanted to talk about it because we never talk about it, and it's very important.
It is very important, and I couldn't agree with you more. And it's worthy of its own living room, really, if I'm being honest, when we're talking about the burden of financing your cancer care, not even just as it relates to the cost of the therapies that may or may not be covered, but we're talking about food insecurities, people that do not have money for food, people that do not have money for gas to get to and from their appointments. It's a very, very real thing. And I think an even bigger problem, and those of you who are new to this program have heard me talk about this before, is that there's not enough money to go around, particularly for lung cancer patients. There's a lot of really great groups out there doing wonderful jobs raising funds, but they kind of bucket it out, right? And so by the time a fund opens specific to lung cancer, more likely than not, within 24 to 48 hours, it has closed because the burden is so high. And I think, anyway, I think it's worthy. We've done it before. I think we did it about 2 years ago around financial toxicity, but it's it is time to revisit. One of the other statistics I think that I found fascinating that I'd never really thought about, but I guess made sense in the context of conversations Dr. Florez and I have had over the years, is divorce and separation rates being higher when the woman is diagnosed with lung cancer. So that too attributes to some of these burdensome sort of issues when thinking about, financial toxicity. Pat, you have a question?
Yeah.
You're okay.
Okay. It seems there's one other component, and that is insurance. I have long-term care insurance, which is determined by longevity tables. Women live longer than men, so they charge women more for long-term care insurance, and possibly even life insurance and medical insurance. Mm-hmm. I don't even know, but the burden falls on us. Mm-hmm.
By the way, I love your jacket. I really love that. I really love that. I saw it earlier and I was like, who's wearing that? That is true. The policies can be higher. And another thing that we have seen is higher decline, like the insurance decline services related to lung cancer diagnosis, higher in women than men. We just did a very quick study and we're doing a larger study about that. So to anybody who's listening, if it's something in your healthcare bill doesn't make sense, don't just pay it. That's what I told my ladies. Don't just pay it. Bring it to your doctor. Your doctor should know. He doesn't know, they need to find who knows. So if it doesn't make sense in that bill, because mistakes are so common. And these insurance companies don't have our patients' interests. They don't. I had a woman that we went to fertility preservation. That's what she wanted to do. And we run everything by the insurance ahead of time. Then we preserved the eggs, and then the bill came for $23,000. Thank God her mother called me. Because she's like, well, that's the price I had to pay. I was like, no, 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 no. There was a mistake here. Let's get to the bottom of this. And it was a coding mistake. They called her like it was elected fertility preservation. Like she didn't know when she wanted to have kids instead of lung cancer diagnosis. So the bill went for $23,000 to $686. So, and she felt that that's what she needed to pay because women and men with cancer, they feel like, oh, that's what it is. No, no, no. Bring the bill. And if we don't win, it's okay. But at least we fought. Mm-hmm. I actually, a lot of my colleagues hate peer-to-peers. Sometimes I don't like them. But sometimes I enjoy it. Just like, oh, I have everything in my computer. I have 3 screens. And I'm like, let me make this phone call. So what are you saying? What paper from where? How? Let me figure it out. Mm-hmm. So I think if something doesn't make sense, you have the right to ask. And that's a thing that we often don't talk to our patients. Oh, that's what it is. Mm-mm. There's another way. Oh, there's a drug assistance program. There is a card. My patient, 28 years old, was diagnosed with EGFR lung cancer last week. And her copay was $4,000. And she was ready to pay. It's like, you didn't call me? We're going to figure it out. And I called a few people. We figured it out. And her copay was significantly down. So there are ways around. Sometimes the answer is no, but at least we all can sleep saying like we try. Mm-hmm. And it's coding mistakes are very common, very, very common because the coding, you know that insurance takes seconds to make a treatment decision. And that was published in the New York Times, that they take seconds to make a treatment decision because most people are like, oh, it's just deny. So.
Yeah, I think one of the challenges, and it's so exciting and refreshing to hear you talk about this and the way that you're able to manage it with your ladies when challenges like this happen. But I think a very real challenge for 80% of the people diagnosed with lung cancer is that they're diagnosed in smaller community settings where the resources aren't available or their healthcare provider is churning out patient after patient after patient and doesn't have the and different types of cancer, right? Both solid tumor and blood cancers, whatever walks through the door is what they're treating. And so, my wheels are sort of spinning about how GoTo can further help support training or toolboxes for folks on figuring out how to manage some of these challenges. And of course, our helpline, as I'm always like, doing shameless plugs for, is a great place to start when you're having challenges like that because we do have access to a lot of resources if you're not finding the support you need from your healthcare provider. So I just wanted to throw that out. I am being very mindful.
Sorry.
No, go.
If to anybody who's listening this now or later, if something doesn't make sense, call your insurance and ask, can you send me a detail of the expenses? That alone, they have to review it before to send it to you. That alone can make a difference. Mm-hmm. I ask my ladies, just call and say, hey, I want a detail. When you go to a restaurant, don't you check everything to see if you pay your bill? So we're used to paying medical bills like without questioning it. No. They're making money out of our sick patients. Yeah. So request a detailed expense. And send it to me in paper to my house. And I have a highlighter so you can highlight it. Yeah. I've been there myself. I had the super mega Harvard insurance and I was very sick with thoracic outlet syndrome. My ICU bill came to $100,000 and I was billed that. And I was like, send me the details. And I have time. Send it to me. So that could be enough just to ask for that.
Yeah. Well, I think we are. We're going to make a little clip of what Dr. Florez just said.
I love everything that she is saying tonight, but like, how can we educate everyone to question? Because I've paid bills just saying, I don't have time for this.
Yeah.
Right? Or they just don't cover it because I trust the insurance company or I trust X, Y, and Z. So how do we educate people to say, question this, ask for a bill, ask for a detail?
Question it, Agreed.
You have to take matters into your own hands and ask a friend to call with you. And there's lots of ways to do this, but the insurance companies don't want to talk to you. They don't want you to call them, but you're going to, right? We're going to do that now.
Larry.
Yeah.
want to hear
And
from the
talking
man.
about
Oh,
money is the beginning, right? We just been talking about money for around 20 minutes.
Yeah.
Normalizing talking about money and bills and what happens. My patients feel shame. And that's what I come down and say, hey, all these buildings don't belong to me. Until like a month ago, I was still driving my 2012 Jetta since medical school. I had to change it because the mechanic told me he was going to leave me in one of the freeways in Massachusetts. But like, we are all humans, and nobody came from like large amount of money. We all came, I came to this country via scholarship. So normalizing talking about money is so important. And your doctor is not only there to just say, oh, do this, do that. It's like, hey, what is happening at home?
I agree.
Right.
I agree. Larry, Mr. Larry.
This room and this organization is the best way to get educated.
Thanks, Larry. Oh.
I
Along
can
with
say
Larry.
I wouldn't be here if Bonnie wouldn't have given me a trust many years ago when she invited me first to the living room. I was 3 months out of fellowship. So I'm here in part tends to go to allow me to use the registry for the Shoal study and gave me a grant.
Yeah.
So I am who I am, and I'm becoming the second youngest. I don't know if it's confidential. It's going to be public in 2 days. I'm becoming the second youngest FASCO, so a fellow of the American Society of Clinical Oncology. And I couldn't be here if it wouldn't be for GoTo, who believed in me when, this little Latina lady with an accent believed that she's a study cancer human.
I love it. And I think
Okay, we're all going to go out tomorrow and start raising money,
Yeah,
to send
right.
it to her.
you mentioned the shawl study, and I think that we did do a living room. I think it was a special edition living room on it during COVID. But if you could touch on that a little bit, and for those of you who don't know, it was specifically looking at sexual health in women. And I'm not going to say it. Go ahead, Dr. Florez. You tell us what it is.
So this I came to this idea when I was a fellow with Dr. Moore, who was still in the GoTo Foundation, and all my research dates back to my ladies. I still see men though, but I see mostly women. So I had a woman that had the scoriations, her armpits, and I really thought was the targeted therapy. Until one day I sit down and say, hey, what's going on? Like, it's not the targeted therapy. So she was having intercourse through her armpits because it was so painful to have vaginal or anal penetration. And I was like, and I realized I couldn't sleep for 3 days how many times I haven't asked my ladies, how's their sexual health? So I came to Dr. Moore at a World Conference on Lung Cancer and a fellow. And I'm like, hey, I want to study sexual health in women with lung cancer. And then Bonnie was still there in a membership meeting. And then we all met. And they're like, we can do it to the registry. So this was is the largest today study on sexual health in women with lung cancer. And it's the first study dedicated to women and the first study since 1999. And let's all be very honest. None of us fit in the jeans that we used to wear in 1999. The majority. I don't. And we don't use the technology from 1999. So why are we treating sexual health and lung cancer like that, right? So we use the lung cancer registry, and many of these amazing women that are in the living room may have participated, and we learn about the issue. And why is sexual health so important? We know that sexual health affects self-esteem, lowers if the sexual dysfunction has been addressed, decreases depression, decreases anxiety. It helps with your body image. I'm talking about internal things. We haven't even talked about partners, yourself. It decreases the needs of opiates. Pain is better when you're sexually active, if that's what you choose to do. Also decreases the need for medications like benzodiazepines. So there's many benefits about sexual health. And sexual health is not only about penetration, it's about manipulation, self-stimulation. That's what I was traveling with. This is the moment I travel with the vibrators for and the lubricant. God, just to bring it back to Boston. So it makes us feel better about ourselves. When you have an orgasm, you release serotonin, you release dopamine, you sleep better. Let's all be very honest. You sleep better when you have an orgasm, and we need to normalize it as we normalize money. You eat better, you feel better. So why are we stigmatizing orgasms, right? And the perception that patients with lung cancer shouldn't have sex is completely wrong, right? I have a patient right now that's 12 years since she was diagnosed with lung cancer. I put that woman in the Florez study. She was in erlotinib, Florez study. Now she's in another antibody drug conjugate. So I'm expecting her to not have sex for 12 years? I'm sorry, but this is not a combat. We need to let those vaginas be happy. So we studied sexual health, and we brought it to the front.
Oh, gosh.
Lung cancer. It was an oral presentation in Vienna, and 2 months ago, it was in the cover of the Cancer Journal for the first time in history. So what we learned, 77% of the women has some degree of dysfunction with sexual health. And the number one issue was vaginal dryness. So we often feel like it's a big fix that we need to have. No, lubricants, vaginal moisturizers. That's what I always carry them with me. And I have a bowl in my office, a crystal bowl full of lubricant samples. It's funny because sometimes people think it's candy. And like, depends how you see it. Depends how you see it. So I have the bowl in my office to normalize it, to completely normalize it. And I ask my ladies, let's talk about your sexual health. And if you don't feel comfortable, I say, send me a message. So if you don't feel comfortable, you can say a patient gateway message and say, hi, Dr. Florez, I would like to talk about sexual health next visit. You open the door. You know, talking about sexual health is like going to the gym. The first time you talk about it, you remember the sex talk you had with your parents? My parents are surgeons. They use way too many technical terms for me in my sex talk, both of them. My dad is a urologist. He's like, the prepucio of the penis. I was like, what the hell, I'm 12. Okay. So the point is that we found the dysfunction, but we found the fixing, which is lubrication and moisturization of the vagina. And the second thing is that we learned that all the things that we learn about breast cancer don't apply to lung cancer. Shortness of breath was the third most common complaint about affecting sexual health. So we have created these educational sheet with sex positions that require less lung capacity. And we also talk about in the paper and all the talks that sexual health is not only about penetration, it includes cuddling, oral sex, kissing. Sexual health includes touching, self-manipulation, manipulation of your partner, and feeling sexy, you know, with your new changes after a lung surgery, after radiation, after chemotherapy. So thanks to the GoTo Foundation, now I have all these old colleagues talking about sexual health. And I don't miss the opportunity to say vagina in front of them.
And it's so interesting because yet again, this is one of those things where, and I think Dr. Florez, you and I had talked about it when we talked about sexual health. If this were as true and deep an issue for men, well, and we know it is, they've got pills for it, right? And they've had pills for it for a long time, but there's not been anything for women. It's not. It tends to be, I think, a little bit more taboo for women to talk about their sexual health than it is for a man to talk about his. So thank you so much for working, you and Dr. Moore, for working with us and getting that study up and running, and for it having so much success. We are running a little bit over, and I'm going to toss it to you before I close out with some housekeeping and just say, how do you recommend women diagnosed speak with their healthcare providers, particularly if they think they're being sort of sent down the road or gaslit, as you said earlier, and not listened to?
If it's before diagnosis, my number one rule is get your medical record and find somebody else, if it's possible. But finding a primary care doctor is very hard too. So I often tell my ladies, sometimes you need another type of healthcare provider, a nurse practitioner, a physician assistant. People have many skills to provide it. So sometimes we all want to go to the ND. I actually like my physician assistant, OBGYN, a lot, because she listens to me and she's not in a rush. So if you feel that you have a symptom before your diagnosis and you're not being heard, you can find somebody else, or you can demand testing. And you can list the risk factors you have. Asian descent, family history, secondhand exposure, radon exposure. We didn't even talk about radon. Previous radiation, hormonal therapies. All those are risk factors. You can bring it out and say, this is my concern, these are my symptoms. If you have been diagnosed and you still feel that you don't have that relationship with your oncology team, it's good to first mention it to your team to see what can be fixed around. There are many ways in which we communicate. I treat a lot of young patients, and I learned, younger than me, I learned that Generation C, I'm a geriatric millennial, so the younger millennials, the ones born in the 90s, they don't like to be called. They don't like phone calls. Like, when we were younger, you get a phone call, you get excited. The new generation have their phone in silence for the last 7 years. So ways of communication sometimes is the obstacle. So I ask my ladies, how do you like to communicate? Some of my younger patients are like, just send it by a patient gateway. Do not call me. I don't like phone calls. But I have other patients that like phone calls. And I had other patients like emails, and other patients like in person. So communicating with your team about the way of communication is very important, and about your expectations too. Because if you don't share your expectations, it's a very tight relationship. You're not going to have a closest relationship with any other doctor that your oncologist. Because you deliver a baby, and then the doctor's like, baby's out, bye. You get your gallbladder out, you never see the surgeon again. So it's a tight relationship, so make sure you communicate how you want to communicate, right? And your expectations. And if it doesn't work, get a second opinion. When my ladies told me they want a second opinion, like, where? Who do you want? Let me call it right away so we can set that up. Because we're better when we work together. You are not offending your doctor if you get a second opinion. If you get a third, if you got a fourth, it's your health. It is your health. I tell my ladies, when you go and find your wedding dress, do you buy your dress in the first place you went? And if you like it, you probably went back and didn't buy it the same day. The same thing with your doctor. If you don't like it, you can find a second opinion. And sometimes you go to a second opinion to the specialist. Like I told my patients, you get the cake recipe from me, and then you bake the cake in Maine, you bake the cake in Wisconsin. But there is no harm feelings about second opinion. It's your health. Like, I just don't understand how some, I don't know, it's your health. Second, third, fifth opinions.
Yeah, I could not agree more. A huge thank you to Dr. Florez for coming and talking to us tonight. I can't thank you enough. Before we close out, as some of you may know, coming up March 3rd through 5th in Washington, D.C. is our Voices Summit. I know some of you in the room tonight will be there in D.C., some of you watching from your own homes or that will be watching post live. I'll see you there if you're coming. We're really excited because a huge portion of the reason we're there is because of a bill that I think we've talked about here before that most of you are aware of, and it's our women in lung cancer bill, and I hope the number's on here. No, I didn't. But it's our Women in Lung Cancer Research and Preventative Service Act. This legislation that focuses on the fact that lung cancer is exceptionally deadly and devastating disease for women, as I think we've covered and talked about tonight. One of the other things we'll be doing is for fiscal year 2025 is asking for an increase in federal funding to $60 million. So we're thrilled to have all of you out there that can come out and join us. For those of you who are unable to maybe join us, that doesn't mean you can't participate from your very own state, from your very own living room. So please reach out to us if you're interested in finding out what that looks like. I also included some lung cancer facts and figures for women on the tables in front of you. These are the newest facts and figures, also available on our website if you're tuning in virtually. So yay, Voices Summit, Washington, D.C., and I hope to see a lot of you there. Our next Gathering Hope, for those of you who don't know what that is, it's our monthly community social hour where we give all of you the opportunity, along with Michelle and Miranda from the patient services team, to talk in groups, get to know one another, share your stories, learn from one another. That is coming up on March 12th. That is always at 5 p.m. Pacific. Although if you are at the Voices Summit, we will be hosting our first ever live in-person one right after registration. So hopefully we'll see you guys there during that. Our next living room, March 19th, 5:30 Pacific, with Dr. Jared Weiss from the University of North Carolina. He's coming out to have a robust conversation with us about small cell lung cancer. Again, I know a lot of you who watch are diagnosed with non-small cell lung cancer, but the small cell lung cancer space is an incredibly important one to go to into the lung cancer community in general. I remember when I started in this space 20 years ago, 21 years ago now, when my mom was diagnosed, there was not even a non-small cell lung cancer community to be found. And now look at what we've created. So for the last 18, 24 months, we've been working really hard to create the same type of community and environment for small cell lung cancer patients, and there is a ton to learn there, some exciting things coming down the pike, so we're really excited to have Dr. Weiss here to be talking about that. Again, a huge thank you to Dr. Narjust Florez for coming out and speaking with us, to all of you in the room, those of you watching live, post-live, Penn Media for coming in and setting this up, Michelle Zay and the GoTo team who helped pull together the new sort of vibe we have in the living room here. And of course to all of our supporters, Amgen, AstraZeneca, Boehringer Ingelheim, Bristol Meyers Squibb, Daiichi Sankyo, Eisai, Foundation Medicine, Genentech, Janssen Oncology, Merck, Mirati Therapeutics, Novartis, Regeneron, Sanofi, and Takeda. We could not continue to bring this amazing program to our community without your support. So thank you all, and we hope to see you in DC or at the next living room. Thanks, everybody.
So I'll be brave if you're brave. I'll be brave, but only if you're